That's my topic. My talk is the challenge in the area of HCV cure, mainly on the post SVR management. I talked three different topics. One is mainly the extrahepatic symptoms and the outcomes of SPR. And the second, that may overlap the decompensated cirrhosis and the post-SPR, the liver function, and also time, prognosis of portal hypertension. The three is post-SPR, HCC development and management. As presented in Dr. Elimination's talk, since 2014, we have interferon-free DAA treatments available in Japan. Right now, as shown in this slide, 5 regimens used in Japan. This slide shows the result of my university of 4 different interferon-free DAA treatments. First one was asnaprevir and daclatasvir. That is the first generation interferon-free DAA treatment. That the SVR rate was 89%. That was a little bit lower than the other the next generation drugs. And Harvoni's fosfovir, ledipasvir, and paritabevir, onbitasvir, and also grazoprevir and elebasvir, all 3 treatments achieved SVR in more than 95 to 97%, almost perfect SVR. But our problem was the asnaprevir. Many of the patients have failed to asnaprevir, daclatasvir patient. Such a retreatment has long been the big problem in Japan. This is the data by Dr. Toyoda of a very large cohort of real-world interferon-free treatment in Japan. They presented treatment until 2013 to almost 2018. All regimens of interferon-free treatment for naive naive patient, and also retreatment of the failure patient initial treatment. This slide shows the time-dependent trend of SVR in initial treatment with different in interferon-free treatment. As shown in this slide, SVR rate is gradually come to 100% as times go by. This slide shows the a change in the SVR rate of patients who are retreated for the prior DAA therapy. The first several years, we have no evidence of retreatment result. We have retreated such patients with Harvoni's or Bikirax, or some patients have retreated with elebasvir and grazoprevir. Overall, SVR rate was between 16 to 70%. Since 2018, the Maviret, grecaprevir, pibrentasvir has been approved, and from March of this year, sofosbuvir and velpatasvir has been approved. In 2019, SVR rates of retreatment has been greatly improved to almost 98%. That means in Japan, almost all patients can be perfectly treated in initial or second treatment, and can be completely eradicate the virus. The benefit of the SVR and DAA treatment, there's numerous paper, as we all know, there's a numerous paper For the hepatic benefit, of course, fibrosis and cirrhosis can be regressed, and there is a significant reduction in portal hypertensions and improvement of decompensated cirrhosis, and also reduced HCC incidence and also recurrence of HCC. Finally, we have liver. We can achieve reduced liver-related mortality. For the extrahepatic benefit, there is a report on the improves on insulin resistance and diabetes, and also reduced risk of cardiovascular diseases. And cryoglobulinemic vasculitis are greatly improved by interferon-free treatment. Then there is also a report of improved mortality of extrahepatic benefits. This slide shows the extrahepatic manifestation of HCV. Most of the extrahepatic manifestations are immune-related, and that means the treatment used by using interferon therapy can be resistant and not indicated in most of the patients. The most common complications and the most common laboratory anomaly is positive for serum cryoglobulin. And the most common cryoglobulinemia, mixed cryoglobulinemia, is mostly caused by HCV infection. That means skin lesions and also renal and vasculitis. This is a report from France. By interferon-free therapy, symptoms of mixed cryoglobulinemia is most of the symptoms can be greatly improved. At the times of SVR 24, almost 96% of the patient can be reduced or completely free of the symptoms. This is a case we have experienced. This is a case of oral lithium planus caused by HCV genotype 2. The patient has been successfully treated with Sovaldi, and the lithium planus has greatly improved, and the patient has no more relapse this stomatitis. That means the eradication of the virus not only causes a hepatic improvement, but also improves patient's quality of life significantly. Also, there is a report by interferon eradication of HCV, incidence of malignant lymphoma has been drastically suppressed. This is the report by Kawamura from Toranomon University. There is a few reports on DA interferon-free DA treatment, but such evidence should be accumulated more and more from now on. As we have experienced, HCV clearance decreased liver-related mortality, and also significantly decreased extrahepatic mortality. This is large cohort data from Taiwan. The next problem is decompensated cirrhosis. As we all know, Child-Pugh B and Child-Pugh C decompensated cirrhosis, a significant life-limiting factor, hepatitis C. The DA treatment of decompensated cirrhosis has not been approved recently in Japan. Recently, we have participated in the trial sofosbuvir and VEL++RBV for decompensated cirrhosis, child-view stage B, and child-view stage C until 12 points. We have treated sofosbuvir and VEL++RBV for 24 weeks. The result of SVR was overall SVR 22%, and the patient with child-view B and as well as child-view C patient has cleared virus without any significant side effects. By clearance of the virus, in child B patient, after SVR 24, almost 30 to 40% of the patient has improved to child-view stage A, and for the child-view C patient, almost 60% of the patient improved to child-view B at the point of SVR 24. There is a few reports on the effect of portal hypertension after SVR or interferon-free DAA treatment. Of the 9 patients with cirrhosis with portal hypertension and with a baseline hepatic pressure gradient of over 12 millimeter Hg has achieved SVR. Of the 9 patients, 8 patients had a significant decrease FPPG of more than 20%. The baseline male score of more than less than 10 patients has a more significant decrease of portal hypertension. Also, with a small report, we also have experience that even after the virus suppression and with the portal hypertension, the increase of portal hypertension, some of the patients has a significant risk of development of new varices, or some patients with small varices may worsen after, even after the SVR. This is a report of 2015. In the right, the 400 HCV patients has been treated with pegriva, and after the SVR, in the patient without any varices at the baseline, SVR patient has significantly lower rates of development of new varices compared with the patient who did not achieve SVR. But as shown in the right panel, the patient with small varices at the baseline, there is no significant difference in the worsening of the esophageal varices, even with the patient who achieved SVR. That means the portal hypertension, especially at port venous shunting and varices, can be closely followed up even after the SVR. This data shows that a change of HPPG post SVR. In the overall data, by DAA treatment and eradication of HCV, HPPG has been decreased, significantly decreased. But in the patient with HPPG of higher than 16, significant percent of the patients still have a high HPPG even after the SVR. That means not only the virus eradication, the treatment of liver fibrosis even after the SPR is necessary to improve portal hypertension and improve the gastric esophageal development, esophageal varices. In the several drugs has been on clinical trial that does targets liver fibrosis, liver steatosis. Some of these are on advanced phase of clinical trial. And we have participated in one of the clinical trial of vitamin A coated liposome who carries siRNAs for HSP47. That means intracellular chaperone that helps for the collagen protein in the activated hepatic stellate cell. This siRNA specifically target human hepatic stellate cell and blocks the generation and the production of collagen fibers. And we have administered this siRNA once a week for 5 doses, and this is the early phase of phase 1 trial. As we reported, some of the patients had improved fibrosis and F4 to F3, and some patients improved F3 to F2. As shown in the right panel, liver elasticity has improved especially in a cohort who have administered enough amount of HSP47 siRNA. The next problem is development of HCC post-SVR. As we have confirmed, interferon and also interferon-free treatment suppress development of newly development HCC in chronic hepatitis and also liver cirrhosis patients. But we all know that risk of development HCC post-SVR that contains cirrhosis and in a patient who have diabetes and a patient who have an older age of older than 65 years of age. These 3 factors are risk of HCC development post-SVR. We have analyzed the risk factors of HCC development post-SVR by 390 patients. The one was cirrhosis, presence of cirrhosis. Patients with cirrhosis have significantly higher risk of HCC development. And also the next significant factor was with past history of HCC. That was the strongest factor with past history of HCC. Patient has a very high risk of HCC development post-SVR. When we done univariate multivariate analysis, only 2 factors, history of HCC and cirrhosis, was the only dependent factor who are directly related to post-SVR HCCs. And as reported, there was a report of recurrence tumor, accelerated tumor recurrence in a patient who were treated with interferon-free therapy. But subsequent report has most of the subsequent report has a negative report. This is a report by French who have conducted survey of patients who are treated and untreated patients. Both patient group has an equal risk of significant HCC recurrence. And also in the United States, risk of recurrence was not accelerated by interferon-free DAA therapy. But this is a report of Singer et al. And very recently, same groups has reported overall survival of the patient with a history of HCC who are treated with DAA and untreated. The overall risk, survival was significantly longer in the DAA-treated patient. As Dr. Enomoto has presented, such data has been confirmed. We still have merit of DAA treatment even in the patient with history of HCC. And here we summarize my presentation of the extrahepatic complications. SVRs improved almost all of the extrahepatic complications and greatly improved patient QOL and extrahepatic survival. And for the decompensated cirrhosis, has been improved by the DAA treatment, but still portal hypertension and varices progression and its prevention is the main problem post-SVR. And post-SVR HCC is not being, seems to be accelerated by SVR. And SVR improves survival of patients with a history of HCC. Okay, thank you for your attention.